This is Dr. Caroline Peterson and Natural Women's Health Institute. I'm talking today about ovarian cancer. Recently, my neighbor was diagnosed with stage 4 ovarian cancer, and I also met a woman who had stage 3 ovarian cancer. So I thought this is probably a good topic to talk about since it's in my life right now. And it's also something that I always think of when I'm working with visceral manipulation of the ovaries and the uterus and the pelvis. So when we think about the ovaries and see a picture like this, it looks like the ovaries are lined up with the uterus, and that they're just kind of in the front of your lower belly where you can probably feel them if only you knew how. So that's what the pictures like this look like. But if you look from the side, you can see that the ovary up here is actually kind of behind the uterus. It's back towards the back. It's more towards the back than towards the front. So that typically on a pelvic exam, the recommendation for palpation of the ovaries is actually through the rectum, not through the vagina, because you can see the rectum is back here, so that it would be actually like closer to the ovary than the vagina is over here. And so, of course, this all is like a weird scale and not actually what things feel like when you're actually doing the exam. The picture looks like, how could you ever feel the ovary? It looks like 10 miles away, but it's actually like not 10 miles away, and you can palpate it. But even though this is the standard for palpating the ovary, and it's the way that all pelvic exams used to be done, it's typically not the way pelvic exams are done by and large nowadays. Nowadays, people generally take a shortcut and just do the vaginal exam without the rectovaginal exam, which is where you have one finger in the rectum, one finger in the vagina at the same time. And that's actually the best way to check for the ovary. But that's kind of gone out of favor. For some reason, that's not done too much anymore. And then now in this picture, this is the transverse plane. So this is like cutting you through the belly button. And this is the back of the body. And this is the front of the body. So you got the bladder, you got the uterus, you got the rectum. And you can see the ovary here is going way back. So you can see the ovaries are pretty far back. So it makes sense that you would need access to the posterior wall of the body to have the best chance of being able to palpate the ovaries. So ovarian cancer is a kind of cancer that, even though it represents only 4% of all women's cancer, it's the 5th most common cause of cancer-related death in women. And that's because it's very difficult to diagnose early when it's easy to treat and turn around. Most ovarian cancer is not caught until its 3rd or 4th level of severity. So it's very, very advanced. So it accounts for 1/3 of all the gynecologic cancers, but for 2/3 of all of the gynecologic cancer deaths. So it's a serious cancer, and one that is not well surveilled or identified early. Interestingly enough, it has the highest prevalence in Western Europe and North America. This could be because some of the risk factors are things that we find more commonly in Western Europe and North America, such as living to an older age, not having kids, having unopposed estrogen hormone replacement therapy after menopause, and things like that. The BRCA genes are also a risk factor for ovarian cancer, as is family history. So if you had somebody else in your family with ovarian cancer, that will increase your risk. If you had a different kind of cancer, then that will increase your risk of ovarian cancer. Of course, if you went through menopause late, that would mean that you've had more exposure to estrogen potentially. And so that also would be a risk factor for ovarian cancer. Smoking is inflammatory and increases the risk for ovarian cancer, as does eating trans fats or monounsaturated fats, which can both be inflammatory in nature. So what we're seeing here is high estrogen, high inflammation, and a family history are all risk factors for ovarian cancer. Interestingly enough, Black women are at a lower risk for ovarian cancer. But because ovarian cancer is detected later in Black women, they actually have a poorer survival rate and thus a higher mortality rate. Most ovarian cancer is epithelial. And this type of cancer is actually well picked up by the lab tests that we have. So that's good news. One of the problems with ovarian cancer is that the symptoms that it presents with in the early stage are generic or really seem unrelated to the ovaries. So some of the very first symptoms, nobody's going to think about ovaries because they're neurologic symptoms. So you may not have good balance, you may not be able to move well, you may have weird eye movements and dizziness, you may have double vision, things like that. Nobody's going to be like, oh, I think I have ovarian cancer. But these are actually some of the first symptoms in some people, not in all people. And that's because ovarian tumors can cause an autoimmune response to the cerebellum. And so then these are all symptoms of cerebellar degeneration, and that can be caused by autoimmunity of the cerebellum caused by ovarian cancers. The other symptoms that ovarian cancer in the stage 3 and 4 can cause are just generic. You're tired, your tummy's full, you have bloating or nausea, you don't feel like eating, you get full early, you may have urinary tract infections or other symptoms related to the bladder, either some change in your bowel movements, getting softer or harder, more frequent, less frequent, something is changing. You can have weight loss and then pain. Since the ovaries are far back, you can have pain in your back or the pelvis or pain with sex. There's lots of things that cause those kinds of symptoms. Is it GI? Is it something to do with the gynecologic system? Is it something to do with the urinary tract? It's unclear because these are kind of like very unspecific symptoms. One of the other things that's kind of unusual and only in the very advanced stages is something that's called the Sister Mary Joseph nodule. And this is when the ovarian cancer has already metastasized or spread to other areas. And this will show up as a nodule or a lump and discoloration around the umbilicus. And what has happened in this case is that the lymph or the blood or even the median ligament of the bladder that goes between the bladder and the belly button has carried the cancer cells up to that area. And then you have a growth of cancer in that area around the belly button, Sister Mary Joseph nodule. Another indication of ovarian cancer could be these age spots that you get. These are called seborrheic keratoses, which are very common with aging. So if you maybe get a whole bunch of these that are new or that the ones you have change in size and start growing, then this can be a sign that there's cancer growing somewhere. And because ovarian cancer is so hard to find and it usually shows up late, this is one of the cancers that you have in the back of your mind if you suddenly get a whole bunch of these, or the ones you have start getting real big. And that's the sign of lesser trelot. So ovarian cancer has similar signs to other things, including ovarian cysts. Ovarian cysts are benign, and sometimes self-limiting. Sometimes they need to be surgically removed, but they also can produce the same kinds of pelvic or low back pain, pain with sex, change in the bowel habits and the urinary habits. They have the bloating, the feeling full after eating. Now, ovarian cysts will cause weight gain, but cancer causes weight loss. So that's one of the difference between the two. And so both of these things, if you have these kinds of symptoms, always a good idea to get a transvaginal ultrasound as a first line screen, because that will potentially give you more information about what's going on with the ovaries. So the rectovaginal exam, like I was talking about in the beginning, is something that we'll just do in the office, and is a screening. It's not a diagnostic exam, and it's not, great at picking up changes to the ovaries because, you saw the pictures. It's really just when things are very advanced that you're going to find changes in the ovaries on the rectovaginal exam. Then because of cancer, you might have more fluid in the abdomen. And so when you do the abdominal exam, you may not actually be bloating. You may be finding some fluid in the abdomen. And then you're thinking, oh, okay, I wonder, I think we may be going this direction. Sometimes with the advanced ovarian cancer, then even the lung exam will change where there are pleural effusions. And so the lung sounds are decreased. And then, of course, the imaging is going to be better than these kinds of screening tests. So I mentioned the transvaginal ultrasound, where you're getting a good perspective on the ovaries. People will also do the pelvic of the abdominal ultrasound also. And then more conclusively would be MRI of the pelvis in particular. And sometimes people will do a CT or a PET scan. But I think MRI is one that's a little more common. The lab that's typically ordered for this would be the CA-125. And so that's for the epithelial ovarian cancer, which is 90% of ovarian cancer. However, it's not specific to ovarian cancer. It will also be elevated if you have endometriosis, if you're pregnant, if you have the ovarian cysts and inflammation. So it's not a standalone test. Another more recent lab test is the HE4, the human epididymis protein 4, which is very sensitive for the serous and the endometrioid types of subovarian cancer. So this can be added in nowadays in addition to the CA-125. If you have a transvaginal ultrasound, if the woman is postmenopausal and you have a positive CA-125 and HE4, then the specificity rate can be up to 96% for ovarian cancer diagnosis, just knowing that information. So that's pretty good. So the International Federation of Gynecology and Obstetrics stages ovarian cancer by laparoscopy. And so that's when you have the little cuts in your stomach and they blow air into your stomach, and then they look in there and see what's going on. And so if you have a stage 1, that means that the tumor is just in the one or both ovaries. A stage 2 is the tumor in the ovary or ovaries and then extends into other tissue, but still within the pelvis. The stage 3 is in one or both ovaries, and now it's extending out of the pelvis into the peritoneum or behind the peritoneum. Stage 4 is still in the ovaries, and then there is metastasis or cancer cells that have gone other places besides the peritoneum or the retroperitoneum. The treatment is taking the ovaries and the fallopian tubes. Another option, if the uterus is involved, would be also removing the uterus. And commonly, chemotherapy is added to one of those surgeries. Because ovarian cancer is typically caught very late, there is an 80% probability of reoccurrence or progression if it's caught late. If it's caught early, the survival rate is 70 to 92% at 10 years, but at stage 4, it's down to 6%. So it's really important that we find better ways of diagnosing ovarian cancer early. We need better screening. Now, for conservative medicine, some naturopaths and chiropractors specialize in natural cancer care, and they are a good team member for people who want to support the body in its healing. I'm not trained as a natural cancer specialist, and so I don't have that education to be able to support in that capacity, because these folks who do have that training will have specific protocols for each type of cancer and each stage of cancer, and that's like a 2 or 3 year training program that I have not gone through. But I know some people who are specialists, and I can hook you up. My brother is an awesome chiropractic internist, Chris Peterson, and also completed several years of postdoctoral training in management of cancer with natural intervention. Manual hands-on therapy, such as visceral manipulation, can be very supportive after surgery once your doctor has given you permission to get that type of care, which is generally at least 8 weeks post-op. We do not treat people who have active cancer with manual therapy, because manual hands-on therapy can actually spread the cancer, because cancer cells can be spread through the blood or the lymph. And so if you get manual hands-on therapy while you have cancer, then it can actually not be a helpful thing. So we want to wait until the cancer is not active, and then we can work with adhesions and things like that that have been caused by the surgery, or if people have had radiation or things like that.